We'll be recording this webinar. So if you don't want to be on the recording, please drop off now and then you can watch the recording at a later date. I'm Katie Meekerin and I'm a nurse with the immunization program. I, along with Megan Carey, our nurse program coordinator, will be the primary speakers for today, but we'll also have a few guest speakers from the VFC compliance team and the immunization registry. As I mentioned, we're recording this, so drop off if you don't want to be a part of the recording, and we will send that out and make it available. Here's a quick overview of our agenda. We will have Q&A at the end. Feel free to put questions in the chat throughout the presentation. We have several team members monitoring who can help field those questions. But we won't be pausing for any verbal questions until the end, so please remain muted until the end of the call. If there are any questions we don't get a chance to answer, we'll send those answers to everyone out at the end of the call, along with a Q&A follow-up with all questions and answers. So I'm going to go ahead and jump right in with COVID-19. We will have an updated COVID-19 vaccine this fall. The FDA and CDC are regularly evaluating and assessing the vaccine effectiveness based on the circulating strains. So based on that, they have recommended an updated vaccine for this fall. It looks like they're moving towards a seasonal pattern for COVID-19 vaccine, but it's still not considered a seasonal vaccine because they're still using that data monitoring and surveillance to determine when is the best time to update the vaccine based on the strains that are circulating so we can get the best protection from the vaccine. The FDA recommended that manufacturers produce a monovalent vaccine with JN1 lineage for the 2024-2025 season. And then in June, they requested that manufacturers use KP2, which is an offshoot of the J1, if feasible. The ACIP at their meeting, they looked at data on the COVID-19 implementation, vaccine effectiveness of the 2023-2024 season, and safety data. And they voted to recommend that everyone 6 months and older receive the COVID-19 vaccine as authorized by the FDA. And then they also told us that we should not anticipate significant changes to the clinical considerations. So for example, those who are 6 months to 4 years old and are vaccine naive will still need those 2 to 3 doses depending on which brand is administered. And then over here on the right side of the slide, you can see at the top a timeline that CDC shared at the ACIP meeting. So as you can see, they said that the vaccine may be available as early as mid-August, but according to this timeline, perhaps also sometime in late September. We are going to have the 3 vaccine brand options again this fall, the 2 mRNA vaccines, as well as our more traditional vaccine mechanism, Novavax. Moderna has indicated that all of the COVID-19 products will be available in pre-filled syringes. So this is great. As you may remember, last year we had the overfilled vials that caused some confusion for the youngest age group. So pre-filled syringes is what we're hearing from Moderna. Pfizer has shared that they will have a mix of pre-filled syringes, single-dose vials, and multi-dose vials, depending on the age. And then Novavax has also indicated that they're going to have pre-filled syringes. We do recommend that providers select one product so that you can reduce errors and not take up quite as much room in your units. But if you do need an additional product, so for example, if you have a number of patients who specifically want Novavax or Pfizer and you're only offering Moderna, you can reach out to the immunization program to order. And then we do know that Pfizer will be direct ship again, whereas Moderna will be centrally distributed. We've been told we'll be under allocation and there may be some delay in getting the supply amped up, but we're not hearing anything that makes us think there are going to be significant supply issues. So for example, it's not going to be expected that all the supply will be available right at the beginning, but it's going to trickle in for the first month or so, similar to how it's done in the past with flu vaccine season and other vaccines. We'll be getting the vaccine as they continue to manufacture it and supply it throughout the season. And then, of course, we would love for flu and COVID-19 vaccines to be available and ship at the exact same time so we can do co-administration from day one, but we don't necessarily anticipate that actually happening. So we'll just kind of wait and see. So we want to make sure we are normalizing messaging to our patients and community members that they'll be able to access a vaccine, but not necessarily everyone will be able to get one within the first few weeks as supply is ramping up. So we also wanted to share some updates about community access for COVID-19 vaccine as you're doing your planning for the fall season. So as you know, the 2024-2025 will be the second year of commercialized COVID-19 vaccine. So this means the vaccine's no longer provided through the federal government at no cost. Something that is different this year and is really important to note is that there's not going to be the Bridge Access Program this year. The Bridge Access Program was the federal program that provided COVID-19 vaccines at no cost to underinsured and uninsured adults last year, primarily at FQHCs and then also at the participating pharmacies. So uninsured and underinsured Vermonters will no longer be able to access COVID-19 vaccines at the pharmacies at no cost, which is a really important change to be aware of for vaccine access. The Bridge Access Program also included funding that supported a number of community clinics, specifically for underinsured and uninsured adults last year. That funding is also gone with the closure of this program at a federal level, and there won't be other funding to support those clinics this year. There will be the AAP grants again, so keep your eye out for those for the providers who are offering COVID-19 and flu clinics. But I do want to just say that those are available through some VDH COVID-19 funding, so this might be the last year for those grants. And just a note, we are aware that pharmacy capacity and healthcare system capacity in some areas really remains strained. And so we really, really want to encourage providers to consider purchasing COVID-19 vaccine for those who are 65 years and older. We heard really clearly last year, and you may have as well, that the provider office is the preferred access point for many Vermonters. And just a note that COVID-19 vaccine is reimbursable through Medicare Part B, which is the same way that the flu vaccine is reimbursed for Medicare. And then we just really quickly wanted to share some slides from the ACIP meeting about the burden of disease for COVID-19. So here you can see that the older population continues to see the highest burden of disease. And then this slide is comparing the number of pediatric COVID-19 deaths to pediatric flu deaths last year. And now I'm going to give it over to Megan.
Thank you, Katie. We're going to move forward with discussing influenza for the 2024-2025 season. Next slide. All flu vaccines for the 2024-2025 season are anticipated to be trivalent in the United States. Previously, quadrivalent flu vaccines were used in the US. The B. Yamagata strain was removed from flu vaccine since it has not circulated in the population after March of 2020. Per CDC, while influenza vaccines are safe and effective, the manufacture and use of inactivated and live attenuated vaccines containing B. Yamagata lineage viruses pose a theoretical risk of reintroduction of the B. Yamagata lineage virus back into the population. This risk can be mitigated by removing the B. Yamagata lineage virus from the vaccines. Other countries may still be using the quadrivalent influenza vaccines as they begin to switch over to the trivalent manufacturing. To note, we may continue seeing the quadrivalent flu vaccines on vaccine records of individuals coming from outside the US. People who have received the quadrivalent flu vaccines during the flu season for 2024-25, they do not need to be revaccinated. It is approved. Next. I'd like to take a moment to briefly discuss the flu vaccine composition. Trivalent flu vaccines are formulated to protect against 3 flu viruses. These 3 flu viruses include an H1N1 virus, an H3N2 virus, and a B. Victoria virus. The composition of this season's vaccine has been updated with a new influenza A, or H3N2 virus, as noted on the screen in the red text. Next slide. CDC recommends everyone 6 months of age and older, with rare exceptions, to receive an updated 2024-2025 flu vaccine. This year, there is a new recommendation that states that adults 18 through 64 years of age with a history of solid organ transplants may receive the high-dose inactivated or adjuvanted inactivated influenza vaccine. Unfortunately, we will not have either of these vaccines available through state supply at this time because they're not on state contract. Provider practices can private purchase these vaccines, or they can refer individuals to a pharmacy. Next slide. This slide displays key details for timing of influenza vaccines as well as guidance for vulnerable populations. Providers can vaccinate at any time during the respiratory virus season as long as influenza viruses are circulating, but September and October remain the best times for most people to receive flu vaccines. There, of course, are some exceptions for this for special populations that may be vaccinated earlier. An example of this is a pregnant individual in their third trimester who would be getting vaccinated in August to provide passive immunity to their infant who will be too young to be vaccinated. Pregnant individuals are at an increased risk for serious complications from the flu virus. We want to call special attention to the importance of vaccinating pregnant individuals for their protection as well as the passive immunity passed on to the infant. Some children will need to receive 2 doses of flu vaccine this season if they're getting vaccinated for flu for the first time, have only previously received 1 dose of flu vaccine, or if their flu vaccination history is unknown. There is a preferential recommendation for individuals 65 years and older to receive high-dose or adjuvanted flu vaccines. People 65 and older are at higher risk of developing serious complications from the flu. And per CDC, in recent years, it is estimated that between 70 and 85% of seasonal flu-related deaths have occurred in this population. And also 50 to 70% of seasonal flu-related hospitalizations have been in this age group. Providers are encouraged to begin early planning for the upcoming flu season. Next slide. I'm going to take a moment to discuss the avian influenza A H5N1 outbreak. There has now been 4 confirmed human infections with the highly pathogenic avian influenza A or H5N1 virus in the U.S., associated with an ongoing multi-state outbreak of H5N1 in dairy cows. Cases have now occurred in 3 states, with 1 being in Texas, 2 in Michigan, and 1 in Colorado. All cases have been mild with mild symptom profiles. And the current risk of these viruses remains low to the general public. However, people with job-related or recreational exposures to infected birds, cattle, and other animals are, of course, going to be at higher risk for infection. There are no concerns for safety of pasteurized milk products. So although the seasonal influenza vaccines do not provide protection against H5N1, they do provide protection against the seasonal influenza virus, which may decrease genetic interactions between H5N1 and the seasonal flu. Consider using presumptive language with farmers and farm workers to ensure these populations who are at a higher risk are protected. An H5N1 vaccine is being developed for the Strategic National Stockpile. And Katie will be presenting on our next topic.
Thanks, Megan. So now I'm going to switch us to RSV, which you're likely aware includes a number of products for a variety of different age groups. So I'm going to start with the products available to provide protection for infants from RSV disease. So just as a reminder, there are 2 products available, the RSV vaccine Abrysvo, which is administered during pregnancy, and then Nirsevimab, the RSV monoclonal antibody administered after birth to the infant. So this image here is from the CDC, and it provides a great visual of the timing for administration of the 2 products. So you can see September through January has the orange part, and that is when Abrysvo can be administered to the pregnant individual. And then October through March, with the parts in blue, are when Nirsevimab can be administered. So then anything with orange and blue is the overlap of when they can both be administered. And then those infants who are born during the white months, April through August, should receive Nirsevimab in October to be protected during their first RSV season. So just some quick updates and reminder about Abrysvo for pregnant individuals. Again, it can only be administered September 1st to January 31st to a pregnant person who is 32 weeks to 36 weeks gestation. And Abrysvo is the only RSV vaccine approved for use during pregnancy, so you cannot use the other two on the market. Our compliance team has been really hard at work enrolling OBGYNs and doing extensive outreach to all the OBGYNs. We have approximately 10 to 12 OBGYNs enrolled. So vaccine can be accessed at those offices as well as enrolled provider offices and then the pharmacies as well. So if you have a patient seeking access, those are access points. At the ACIP meeting, they did share that there is not currently any updated effectiveness data from this last season due to the limited uptake and then the short turnaround in the season. Another really important update discussed at the ACIP meeting. So currently the recommendation is for a single dose per lifetime per pregnant individual. So if someone was pregnant in 2023, 2024, and they received Abrysvo, and then they're pregnant again during the 2024-2025 season, they cannot receive an additional dose of Abrysvo in the subsequent pregnancy. Instead, that infant will need to receive nirsevimab. There just currently is not enough data to support a recommendation for a dose during pregnancy around effectiveness and safety. So it's a single dose right now per lifetime per pregnant individual. Okay, I'm going to move us quickly to a review of nirsevimab and the recommendation of this product. It's a universal recommendation for any infant 8 months or younger who was born to someone who did not receive the RSV vaccine during pregnancy. Really important to note that it is weight-based. And also there is the recommendation for children that are entering their second RSV season, those who are 8 to 19 months, who are at increased risk of severe RSV disease. And then on the right-hand side, we put a screenshot of the top part of a really incredibly helpful visual resource from the AAP, and then it's linked there below. I highly recommend accessing this resource and sharing it with your colleagues, as it's a really great decision tree tool that you can use to walk through eligibility and dosing. So here are considerations for administering nirsevimab. First, really just want to emphasize the need for coordination and collaboration between the OBGYNs and birthing facilities to determine what the plan is for protecting infants in your community. Make sure you know what your birthing facility's plan is for administration. There are a number of VFC enrolled birthing facilities, and those are all listed on this slide on the right. But I do want to note that being enrolled does not necessarily mean that the facility plans to administer. There are still a lot of steps between enrollment and having the infrastructure in place to administer. And there may be some facilities that aren't ready to administer this fall, or they may only have certain providers choosing to administer, or they may only have certain units. So really just important to be collaborating and communication with your birthing center and knowing what their plan is for administration. And then, of course, making sure there's a good plan for communicating during discharge which infants have received the nirsevimab at the birthing facility, which infants don't need nirsevimab because they have that passive immunity protection from the administration of Abrysvo during pregnancy. You aren't going to see a linkage of the Abrysvo administration during pregnancy. It won't be linked to in the IMR to the infant, and it's probably not linked in many EHRs. So again, really important to have a plan for how that information is communicated. Also, I just want to note that primary care providers will be the single source of access for nirsevimab for those who are the older infants that were born April through August. And also that the recommendation is up to 8 months universal. So when you're thinking about planning, kids may potentially age out. If they are going to turn 9 months in December, they would no longer be eligible at that time. So they need to get it before they age out. So things to think about when you're doing your planning and communication with providers. So I do want to talk about the 2024-2025 availability. We have reached out to the manufacturer Sanofi to gather additional information, and they did tell us that they anticipate having enough product for around 80% of the birth cohort nationally. And last year, they told us that by the very end of the season, they ended up having about 40% of the birth cohort nationally product for that amount. So that is a really significant increase in the availability of the product, which is really exciting. They have indicated that they plan to front load the 100 milligram doses for those older infants. So those infants who are born April to August, who are entering the RSV season and who will need that earlier in the season before they age out, as I said. So at the ACIP meeting, they mentioned specifically that they expect to have limited availability in early September before the product can be administered. And then they think it's going to ramp up during September and have broad availability by October 1st, when it can actually be administered. But of course, we really want to think about setting those expectations, like I talked about earlier, that not all product is available as soon as the very beginning of the season. We're not going to have everything October 1st that will last us through the whole season. They're really working really aggressively to ramp up production for this product as much as possible. So that means that some's going to be distributed and shipped as soon as it's manufactured. So product that's being produced in December, January, and February, we're going to be getting as it becomes available, and they'll be sending it across the country. So again, key message for this year is working to normalize the rollout of products rather than the immediate availability of all of the product at the beginning of the season. So really exciting news. We did hear from Sanofi that they analyzed additional data that supports a cumulative temperature excursion that aligns better with the other products in our units. So as you may remember, last year we had to waste a number of doses because we did not have good data. There wasn't data available to support viability of the product after temperature excursions. So of course, any temperature excursion, as always, needs to be reported and assessed by the immunization program, but this gives us some extra breathing room. So we were really excited to hear that and share that news. The other really exciting news is about the effectiveness of this product. There was an MMWR released recently that the product was 90% effective at protecting infants from RSV hospitalization, and that the information shared at ACIP was also really similar to that in terms of effectiveness. At ACIP, they also discussed the post-marketing surveillance, as, including the fact that the most frequently reported adverse events included issues related to breakthrough RSV infections. And then there were some cases of serious hypersensitivity reactions with nirsevimab that were identified in the post-marketing setting. So the product labeling was updated in February of 2024 to state that there have been serious hypersensitivity reactions following the administration of nirsevimab. And these reactions include things like hives, dyspnea, cyanosis, and hypotonia. And then also, I really just wanted to take a minute to shout out the great success of the 2023-2024 season. Even though there was a really rocky rollout, it was very frustrating. We still, at the end of the season, had 35% of our infants protected through one of these RSV products. So we know we were able to protect 2,000 infants because of the incredible efforts and work of many of you on this call. So thank you so much. That was a rough season and we still got there. So there's a link to this information, this data brief on the slide, but we just wanted to give a big thank you. And we're really, really excited to see where we can get this year with the increased access to the products and knowing how important and effective this is to protecting those infants. So I'm going to continue to talk about RSV, but I am moving to the older adult population. So based on a lengthy discussion of the data, there were updated recommendations at the ACIP meeting. If you remember, we had a shared clinical decision-making recommendation earlier. The new recommendation is a universal recommendation for all adults 75 years and older to receive a single dose per lifetime of RSV vaccine, and it's a risk-based recommendation for those who are 60 to 74 years to receive a single dose per lifetime of RSV vaccine. So obviously, these were some pretty big changes to the recommendations for older adults. The ACIP received a lot of feedback on the challenges of implementing shared clinical decision-making recommendations. They also looked at the clinical trial data as well as the preliminary post-marketing surveillance data, and they saw an excess of GBS or Guillain-Barré cases associated with the 2 protein subunit RSV vaccines beyond what would occur in the population without vaccination. So based on this post-marketing surveillance and the available burden of disease data, they conducted a risk analysis and they determined that the number of avertable deaths for the two groups that ended up being recommended, so for the updated recommendation, over 75 years and 60 to 74 years with a chronic condition, that was much larger than the potential for GBS cases. So they also reviewed cost effectiveness data as a part of this update. I really want to point out that the post-marketing data is preliminary, as they're still needing to do the actual chart reviews and gathering information about these cases. So this is, they took into account all the information they have now and updated those recommendations so that we no longer have that shared clinical decision-making recommendation, and hopefully can be really clear about who should be vaccinated with the universal and the risk-based recommendation. So I also wanted to share this slide from the ACIP meeting, which demonstrates those chronic conditions that fall within the risk-based recommendation for 60 to 74 years. I want to specifically point out that the risk-based recommendation doesn't include people with isolated hypertension. It only includes people with chronic kidney disease that is considered advanced, and it only includes people with diabetes that have end organ damage. So they did get some really specific pieces here. But I do want to note that there is some provider flexibility in this last bullet point on the right-hand side, where it lists other chronic medical conditions or risk factors that a healthcare provider determines would put the individual patient at increased risk. And finally, I just want to point out that that bullet point above that one that says that a risk factor is also residence in a nursing home or another long-term care facility. So again, anybody that falls under one of these risk-based recommendations should receive the RSV vaccine. Other brief updates from the ACIP meeting include confirmation that the RSV vaccine can be co-administered. There's not any new data on co-administration yet. And also just confirmation again that it can be administered year-round, but they did state that the best time for administration is late summer, early fall before the RSV season begins. So when you're thinking about co-administration and the timing of administration, of course, you want to consider the patient's likelihood to return for an additional vaccine or their likelihood to return for the best time of the year to get it. You also want to think about their preference for co-administration. You want to consider the potential for increased reactogenicity. And just there's a lot of factors, but it's available to be co-administered at any time of year. And then really important, I want to note that the current recommendation is only 1 dose per lifetime. It's not a dose per season. They are currently reviewing data. There are clinical trials ongoing looking at waning immunity and if there's a need for an additional dose. So we'll hear more and we'll keep you updated, but it is right now 1 dose per lifetime at this time. So as you may have heard, there's a new RSV vaccine this season for older adults. Moderna has an mRNA vaccine, Mrezvia, and it's also single dose like the others. I do want to point out importantly that the storage is different for this one. It's a pre-filled syringe that's frozen and has to be thawed prior to administration. And we have a link there to the package insert. And then here you can see the most commonly reported adverse reactions. So not unexpected injection site pain as the highest, and then some others there listed. I also want to point out that some of the safety signals that were seen in the other RSV vaccine trials and post-marketing were not seen in the clinical trial for this vaccine. So they don't have the cases of ADEM. There's no safety concern for GBS and no imbalance of atrial fibrillation within the clinical studies for this one. And then, of course, because this is an mRNA vaccine, they also looked closely at myocarditis and pericarditis during the clinical trial. And they presented at the ACIP that there were no confirmed cases of acute myocarditis or acute pericarditis. And then I just want to give you a heads up that we have a couple of slides that are things that you can use that have information about all these products if they're helpful resources for you and your team to print and share. And now I'm going to turn it back over to Megan.
Thank you, Katie. I will now be leading our next discussion on other vaccine updates. Next slide. ACIP now recommends PCV21 Capvaxive for adults in the US who are aged 19 and older who currently have a recommendation to receive a dose of pneumococcal conjugate vaccine. This recommendation includes adults 65 years and older who have not previously received PCV or whose previous vaccination history is unknown, adults 19 to 64 years of age with certain underlying medical conditions or risk factors who have not previously received PCV or whose vaccine history is unknown, and adults 19 years of age and older who have started their pneumococcal vaccine series with PCV13 but have not received all recommended PPSV23 doses. CDC is updating their materials to align with this new recommendation. So when referencing CDC sites, you might see that they have information at the top of the page noting this new change, but some of the actual details around PCV vaccines are not fully updated with this new recommendation. PCV21 is not currently available for ordering because it's not yet on our CDC contract. We will provide an update when this vaccine is available to order. Next slide. I'd like to quickly draw your attention to the visual on the screen. This table displays a comparison of serotypes to the various PCV vaccines. Unlike PCV15 and 20, PCV21 does not equal PVC20 plus 1 serotype. PVC21 has several serotypes on it that are not in PCV20. PCV21 covers 81% of the pneumococcal serotypes commonly found in adults. So although the vaccine loses 13% of the serotypes that were in PCV20, it does gain 36% of other serotypes that are commonly found in adults. Next slide. This slide displays the proportion of invasive pneumococcal disease by vaccine type and age group. 54 to 62% of IPD cases in adults were due to PCV20 serotypes. 77 to 85% of IPD cases in adults were due to the PCV21 serotypes. So again, PCV21 covers a majority of the pneumococcal serotypes commonly found in adults, and it does give healthcare providers another option for protecting adult patients from pneumococcal infections. Next slide. I'm now going to discuss an update related to Vaxelis. Hib polysaccharide conjugate vaccines are the primary prevention strategy for Hib disease. Historically, Hib meningitis peaked at a younger age in American Indian and Alaska Native infants, which resulted in a preferential recommendation for PDVax Hib for this population. Data had demonstrated a protective antibody response after the first dose. During the meeting, ACIP reviewed clinical trial data on post-dose 1 immunogenicity of Vaxelis that resulted in a vote for Vaxelis to be added as an additional option for this preferential recommendation for American Indian and Alaska Native infants. ACIP voted to include Vaxelis based off from the Hib component of the vaccine. This change increases flexibility for patients and providers and may reduce the number of injections to complete the childhood immunization series for those who receive it. Just as a quick reminder, Vaxelis is not recommended for use as a booster dose, so a different Hib-containing vaccine would need to be used for a booster. Next slide. ACIP also discussed meningococcal vaccine recommendations at the recent meeting. However, no clear decisions or votes were made, so no changes at this time. A working group will revisit the adolescent meningococcal vaccine schedule, including a discussion on protection for higher risk ages, also reviewing epidemiology, as well as the duration of induced vaccine protection. VDH is holding off on adding pentavalent Penbrea until we have updated ACIP recommendations, and this is just to limit vaccine errors. This discussion will continue at the October 2024 ACIP meeting. Next slide. All right, a quick update on GSK products. We did add some information on this in the latest provider update email, but we wanted to ensure that we provided this info at this meeting as well. When administering GSK vaccine products, providers must use extreme caution as the tip caps of the prefilled syringes may contain natural rubber latex, which could cause allergic reactions for individuals who have allergies. GSK is currently transitioning production to prefilled syringes without natural rubber latex, but this could take several years for the full transition because the already produced syringes will take many years to expire. Providers can determine if they have a product containing latex by looking at the package insert and box of the vaccine to be administered. We're encouraging providers and staff to not look at the package inserts on the FDA page as they reflect the products that are currently being produced without latex. So again, to ensure patient safety and prevent medication errors, staff should be reminded of the importance of checking the box and package insert inside the box prior to administering GSK products. Now, just a quick note on this, in the provider update, we talked specifically about the Tdap vaccine, but this is actually applicable to many of the manufactured GSK products. Thank you. Katie will be leading our next discussion.
Thanks, Megan. So we are really excited to say that we now have inactivated poliovirus vaccine available for adults. This matches the updated ACIP recommendation from October. I do want to provide a little bit of additional guidance about the recommendation. The CDC has given clear clinical context that in general, unless you have a specific reason to believe an individual was not vaccinated, most adults who were born and raised in the United States can assume that they were vaccinated for polio as a children. And also, CDC has stated that verbal reports of previous vaccination is acceptable, and we wouldn't expect to see records for most of these older adults or in the IMR just because we didn't have the IMR at that time. So wanted to provide that additional clinical context. And then quickly, here are those updated recommendations from the fall of 2023. The recommendation states that adults who are known or suspected to be unvaccinated or incompletely vaccinated against polio should complete a primary series. And then there's also the recommendation that adults that are at increased risk may receive a single lifetime booster. And just a quick reminder that for primary polio vaccine series, we're looking for 3 doses. Next, I want to talk a little bit about the Mpox vaccine, JYNNEOS. JYNNEOS has recently become available commercially, so it's no longer going to be provided for free through the federal government. We are going to have it available as a part of our Vermont vaccine purchasing program. It is an ACIP recommended vaccine. And just of note, as we work on depleting the last of our outbreak response supply, please reach out to the immunization program to order. Once that's all depleted, it'll be ordered in the normal manner and be added to catalogs and VIMs. And then we also just wanted to make sure everyone's aware that we are continuing to see cases and outbreaks nationwide, including several cases in Vermont this year. So we really want to be diligent about assessing patients and offering the vaccine as appropriate to those who meet the recommendation. And then also as a reminder that individuals need 2 doses for the highest level of protection. So we're really encouraging providers to ensure that you're assessing patients and you're making sure they have that complete series for the best protection. And then also wanted to share this image in case it's a helpful visual for you around how vaccines are covered for Medicare. And as I mentioned earlier, really important, we want to emphasize that COVID-19, like flu, is covered under Part B of Medicare, so in that traditional Medicare billing mechanism. The new RSV vaccines, as well as Shingrix, are covered under Part D of Medicare, which is your prescription drug coverage and is often accessed through the pharmacy. It is possible for providers to private purchase these vaccines and receive reimbursement for Part D. And then Part C is also known as Medicare Advantage and usually includes prescription drug coverage. And of important note, with the Inflation Reduction Act that's been in effect for a while now, there is cost sharing, $0 cost sharing for any vaccine under Medicare Part D. So that means that anybody that has Medicare Part D coverage does not need to pay anything for those vaccines. And now I'm going to turn it over to our compliance team for some updates from them.
Thank you so much, Katie. Next slide. So this picture should be hopefully pretty familiar to you. This was created by our program and it was added to one of our provider update emails. That's a little plug. Please continue to read them fully. There is just so much good information in there. On this graph, I really want to highlight 3 vaccines. The first vaccine is going to be our MMR vaccine. This vaccine can be stored in both a standard freezer and a standard refrigerator. You will hear from my team that we always prefer you to store it in the freezer, and this is strictly for our own good. It is far less likely that you will have any temperature excursions in a freezer with an MMR vaccine because your standard freezer doesn't always go colder than it should, but it can definitely go warmer. And if it goes warmer, it's still in normal range. So therefore, it is not actually having a temperature excursion. And that's why you will hear from us. And we will always say we prefer MMR to be in the freezer, but it can be in both. Second, I want to touch on is JYNNEOS. JYNNEOS is our monkeypox vaccine, and it is currently being delivered from our depot. When it is transferred to your office, it is coming at refrigerator temperature. This means there is already a 8-week beyond due state listed on that box. Once we transition over to ordering it from the manufacturer or from McKesson, it will come frozen, which means you can place it for the first time in the freezer and store it until the end of its expiration. And then once you move it to the refrigerator, it gets a lovely beyond due state of 8 weeks. The last one on this slide is going to be our polio vaccine. We hear so much about beyond due states, and it's super important. Polio does not have a beyond due state. It is a multi-dose vial. We keep it in the refrigerator until expiration, regardless of how many times we puncture it. Should only be a max of 10. But use it until expiration. Do not discard after any type of puncture. Next slide. Next, I'll be talking about COVID vaccine. This is obviously our most difficult when it comes to storage and handling. So I'll first say Pfizer. There are 3 types of Pfizer vaccine. We have our 3-month to 4-year multi-dose vial and our 5 to 11-year single-dose vial. This is shipped on dry ice. This means it has come at ultra cold freezer temperature. There is not a single enrolled provider that has a ultra cold freezer. Therefore, as soon as you receive that shipment, I'm going to need you to place it in the standard refrigerator and mark a 10-week beyond due state. Next, we have our 12+ Comirnaty that comes at refrigerated temperature. There is no beyond due state. It gets in the refrigerator and it's used till expiration. Moderna is all the same storage and handling. Store it in your standard freezer till expiration. Once it's moved to the refrigerator, it gets a 30-day beyond due state. Next slide. Lastly, just a little plug. CDC has a wonderful at-a-glance document. I suggest everybody go and take a look. I will place the link in the chat. Last thing I'm going to say is if you have a chance after this meeting, please just go and take a look at your units and just verify that all of your COVID vaccine is in the appropriate unit. And if it needs a beyond due state, it has the beyond due state. This is really important that Vermonters are being vaccinated with a viable vaccine. Thank you so much. And I'm going to pass it over to Tanya.
Thanks, Samantha. Next slide, please. The last compliance item we wanted to bring up was the auditing of your Senso nodes for your vaccine storage fridges and freezers. This is a question that our team gets asked frequently at compliance visits, and it also came up in our Senso user survey. The simple answer is the Senso nodes must be audited by providers every day because it's a federal requirement. It's a requirement that all enrolled providers take the responsibility to manually confirm the temperatures are are within range for their units. Although Senso monitors temperatures automatically, even the most sophisticated technology requires monitoring and maintenance to ensure it's functioning properly. So without manually monitoring of the temperatures every day, there would be no way for a provider to become aware of a problem with the Senso equipment itself should one arise. I think next up is the IMR team, so I will hand it over to them.
Yes, hello. My name is Jason Pope. I'm the immunization registry technical lead for the IMR team. So the IMR, the immunization registry, is kind of a centralized location which holds all Vermonters' previous vaccinations and their vaccination history. Next slide. So these are all, I'm sorry, next slide. This is a list or kind of a picture of all different practices or locations that can send vaccinations to the IMR. So we have hospitals, pharmacies, nursing homes, clinics, providers as in like small practices or independent providers, urgency rooms, urgent care, and then lastly, health insurance companies. Next slide. This is in terms of the bidirectional response. This is kind of the flow of how that bidirectional functionality works. So it starts off with the provider in the EHR adding or actually adding a vaccine to their EHR, which then goes to Vital, which is our HIE or Health Information Exchange partner, and then they kind of process and push that information to the IMR. And then if the provider is looking for recommendations on a patient's vaccine history, it goes in the reverse order. Next slide. Here is how when a provider queries the registry, different scenarios of what they will receive back. So if they enter a patient's name, first name and last name, date of birth, and the IMR has an exact match, they will receive that exact match back. If the information they enter does not exist in our system, then they will get a message back saying no patient found. If there are multiple patients which could match that patient's name and date of birth, they will receive a list. I believe it could be a pretty large list, up to 10 pages or so. And then lastly, if there are if they query the system and there are within 10 seconds, a large number, 7 to 10 seconds, a large number of queries that are received, they will receive an error message that there were too many matches. Next slide. So an EHR needs to configure itself in terms of accepting a bidirectional, or this, for example, on the right-hand side is an HL7 message. These are kind of the bones of that data message or that vaccine that is sent through that kind of that flow from the provider to the HIE to the IMR, and then that reversed order as well. So this is a lot to look at, I know, but I just wanted to give you a picture of what that looks like. Next slide. So this is a picture of a recommendation in the IMR application itself. So this is a test patient showing which vaccines are recommended, which vaccines in the future will be recommended, and at which date, the earliest recommended and then overdue. And this can look different in each EHR as well, depending on which vendor they have, like Medent or Epic or anything like that. Next slide. Okay, so this is the process in terms of onboarding a provider with bidirectional messaging. First, they have to sign what's called an SLA or a site level agreement. Next slide. From there, the EHR and then Vital or HIE will develop an onboarding plan based off of time, like what their project outline is or the availability they have. Next slide. From there, it's the developmental phase. So this is where the EHR actually has to build itself or allow the EHR to accept that HL7 message, that very large message, which is the vaccine itself. Next slide. Next is the connectivity. So between the EHR and Vital, they will send test case messages based on about 10 test cases that we have previously created that all EHRs use for all testing. Next slide. Next will be the validation stage, which the Department of Health or the IMR team is involved in. That's where we will get a copy of the validation testing that the EHR and Vital have done. We'll review it, and then we'll either pass or say that they need to retest. Next. From there, it's go live. There's a 2-week period where we watch that EHR and just make sure all messages that are coming in are appropriate. They're not missing any information. If they are, then we'll create a ticket with Vital, and Vital will assist us in outreaching and trying to kind of troubleshooting the issue with the EHR. Next. So if a practice would like to, or they're interested in this bidirectional messaging, Reggie Wall, she's a senior application systems analyst at Vital. She is the person that would be outreached, and her email's right there. Next. Next, this is a picture of what we currently have for bidirectional onboarded sites. So currently there's 16 practices or 51 separate sites that are live with bidirectional messaging. And after that, below that, it says there's 15 practices or 35 sites which are in progress to taking on the bidirectional messaging, and then 61 or 175 separate sites that have requested and are in line. Next. For our forecaster and the recommendation phase of the IMR,
Jason, sorry, we're running out of time. I'm gonna let I want to make sure we have time for questions. So we will send these slides out to people, and we really want people to review them. And if you have questions, get back to the IMR team. But there's some great information on here about forecaster update process, because we have gotten questions about that. So if we end up not having any questions, we can come back. But thank you, Jason.
You're welcome.
And appreciate it. So we also just really wanted to quickly share some information about vaccine promotion campaigns that are happening now and in the future, just in case anybody from the community or patients reach out after seeing a promotional campaign. Currently, we have the measles vaccine promotion campaign happening, and that'll end July 31st. We have a year-long plan for upcoming promoting routine vaccines. So we're going to roll out specific messaging for the different audiences at 3 different times this year, starting with the adolescent campaign, and then later we'll have one for parents of young children, infants, and then later adults. And then, of course, we'll have our annual seasonal vaccine campaign for respiratory virus season. It will, again, focus on all 3 vaccine options and have a prevention and vaccine messaging, and that will launch in September or October. And then just want to put in a quick plug for our vaccine data dashboard. This year we will have COVID-19, flu, and RSV, and we expect it to update probably around start updating around the last week of October. We have to get enough immunizations administered to be able to report that data publicly without suppressing every single data variable. And that is it. And so we do now have time for some questions. If anybody has questions, we can field those from the chat, or you can come off mute. Yes, I see a hand raised. I can't see what, but go ahead and ask.
Hey there, it's Purnani Purdue. I am actually asking this question for Village Health. When we were discussing the vaccines covered under the Part D of Medicare, I wanted to ask about that. So my understanding was every time we ever tried to bill anything under the Part D of Medicare, it was never allowed. You had mentioned that is. Do you have any guidance on where that information would come from as far as how Medicare would be billed and how that would actually get covered?
Yeah, so it is complicated. I'll say there's a couple, I can send you some guidance is my primary answer. And some people use kind of like a patch program that lets them bill, or there are a couple other I'm not gonna say it's simple or it's quick, but I will send you what I have.
Yeah, that'd be
And
great because that would simplify a lot of things for our older population in accessing the vaccines for sure.
Yep.
We do buy the high dose flu for our patients, and that is pretty easy and covered because it's Part B coverage. But anything under that Part D, we've never been successful at.
yes, we have heard that before. And I will send you what we have, and am open to chatting too if you have more questions.
Fantastic. Thanks for your time.
Mhm. Other questions? I see one in the chat. Samantha, I'm going to let you or Tanya answer this, but the question is, with auditing the Censo node, is taking temps on paper instead no longer allowed, as in we must audit nodes in Censo daily?
Hi, Katie. Yeah, sorry, I was just responding and I'll continue to respond in the chat. But to answer your question, if your practice requires, paper temperature log to be done, then you can continue to do that. But our requirement is that it is done in Censo. So if your practice is saying you have to do it on paper, I'm saying you have to do it on Censo, then you'd be doing two types of auditing your nodes. But like our bottom line is you do need to do it on paper. That is how we can verify that you are taking responsibility. Thank you.
Go ahead, Catherine.
Sorry, yeah, hi. Thank you for answering that, Samantha. I was asking that question on behalf of Planned Parenthood of Northern New England, by the way. Yeah, so what I'm hearing, so we do have requirements, internal requirements to take temps on a paper log. And a long time ago, I was talking to someone in the immunization program who said, okay, if you're taking them on paper logs, you have it covered. So I just wanted to clarify what you're saying is we would have to make sure we're auditing them in Censo. And if we're taking them on paper, sounds great, but that's not really what you all are interested in. It's more so the documentation in Censo. So as long as that's correct, I can implement that.
Yes, that is correct. Thank you, Kevin.
Okay, thanks so much.
Any other questions? Okay, thank you all for joining us today. Really appreciate your time, and we will be making the recording available, the slides available, as well as giving the Q&A responses to everyone from this time and those that were in the chat. And again, thank you so much. Reach out if you have any questions. We're always here to help.
Thank you.
Thank you.